Hello, I'm Renato Ambrosio from Rio de Janeiro, Brazil, and I'm very happy and grateful for participating in the Rio 2024, the 16th International Conference of the Research Institute of Ophthalmology in Egypt. And I'm honored to participate. I'm sorry for not being there with you. My talk is Multimodal Diagnostics for Corneal Ectasia Paradigm Shift. This is my financial disclosures. I also thank my supporters for the Violet June Global Violet June Keratoconus Awareness Campaign. This is a very important campaign that aims to educate patients about the disease so that we can comfort them, which is a very important part of our mission as medical doctors. I'm also very grateful and honored to be the president of the ISRS, International Society of Refractive Surgery, has been a partner of the American Academy for over 20 years, but since January 1st, 2024, we are independent and more international than ever, with many big eyes. So I invite all of you to join us with innovation, impact, inclusivity, inspiration, and many other eyes with the positivity for promoting excellence in refractive surgery. Refractive surgery has a lot to do with keratoconus. Keratoconus is not a new disease. It was described in the very nice compendium on the conical cornea by John Nottingham over 150 years ago. And this very nice poem from Friedrich von Schiller, written in German, was that only persistence leads to the goal, only abundance leads to the clarity, and the truth lives in the abyss. This is all related to the growth mindset that we have to develop for managing patients with keratoconus, and I would say for doing anything as a medical doctor or anything in this planet. Interestingly, when we see the number of publications that are related to keratoconus, this is the PubMed number of publications, you see an exponential growth starting in the 80s to the 90s, and it is related to refractive surgery. We had a huge paradigm shift, and this paradigm shift related to many paradoxes, especially when we consider refractive surgery and keratoconus. This is a multimodal diagnostic for keratoconus review, and many of the aspects that I'm going to present here is related, but I have only 20 minutes, so I am grateful for this time. But if you want to read, I invite you to, this is available on Eye and Vision, is open access. When we think about advanced diagnostics for ectasia, we have to be considering the whys and hows and what you're looking at. Screening for keratoconus is different than evaluating the risk for ectasia before laser vision correction. The enhanced screening prior to laser vision correction is different than managing patients with disease prior to keratoplasty. When I did my training, keratoplasty, a cornea transplant, was the only procedure that we had available. Now we have rings, we have cross-linking, and we have a lot of work that we can do to help these patients. And we need to be very keen on the diagnostics so that we can do a customized, individualized planning. We have to be objective. We talk about the subjectivity and the limitations on that, but still the need for being human doctors. And we have to understand the whys and the hows. Ancient artificial intelligence and ancient intelligence, which is philosophy, both applied in the algorithm H2I squared, that we will evolve with a growth mindset for continuous evolving, going beyond. But we have to be keen on recognizing that screening for ectasia risk, diagnosing keratoconus, staging the disease, classifying the disease, doing prognostic factors, and clinical follow-up are different evaluations, different diagnostic approaches. And this is a true revolution in evolution because we have multimodal imaging. Since anamnesis, which is the questions that we discuss with the patient, starting with the chief complaint, so that we understand the patient. We have slit lamp, corneal topography, central ultrasound thickness, and tomography with high shine fluid, high frequency ultrasound and OCT, biometry that makes it go beyond cornea. It's refractive because we have wavefront, whole eye wavefront analysis, scattering of the light, and biometry. And it goes even beyond imaging because we have osmolarity, molecular biology, and genetics, and customizing refractive surgery that goes beyond linking the laser with topography or whole eye wavefront for optimizing the planning and understanding how to prevent complications. This would definitely enhance safety and efficiency and efficacy for us, helping the patients the best way as possible. Topography was the very first computerized system to do the diagnosis of keratoconus, and the pioneer work by Aaron Rabinovitz and Peter McDonald in the seminal JRS publication in 1989 is very important because we were able to see objectively some parameters like central K, steep cornea higher than 47.2, and IS value higher than 1.45 as the asymmetry from the upper and lower part of the cornea, superior inferior stiffening, and asymmetry between eyes is also very important. Neural network for classifying corneal topography by Maeda, Kleiss, and Smolek was very important, probably the first, one of the first, if not the first, applications of artificial intelligence in ophthalmology. Interestingly, we think about artificial intelligence, applied artificial intelligence, and ancient intelligence, because all these patterns can be really tricky to look at when you think about different scales. But the pioneer work by Jan Rabinovitz has to be complemented and recognized always, because he taught us that inferior stiffening and skew radial axis are patterns that we must identify. Jan Rabinovitz, I do a tribute for him. He passed away a couple months ago prematurely, and we should honor him with the work that we do to evolve and keep working on the progress for keratoconus detection and management. His major review has about 4,000 citations. It's very impressive. And he also published a very nice atlas on corneal topography with Steve Wilson and Steve Kleiss. And I did my training with Steve Wilson in Seattle, Washington in the early 2000s. And in this very nice review, they finished this review saying that in the future, the pioneers Helmholtz, Placido, and Gustrand will certainly be impressed with the ability that we have to look at topography and to link it with parameters for customized treatments. I was honored to do this publication that looked at 2 years of patients that came as candidates for laser vision corrections. And these 3 cases are examples of patients with mild ectatic diseases. This patient has 2015, 2025 plus, and 2020 minus. And these patients were all subclinical, and ectasia was detected by topography. So the sensitivity is key. But if you see the fellow eye of this patient that has 2015 distance correct vision, this makes the point that we have to go beyond the surface to look at a higher sensitivity. And this is important because we have the conundrum of ectasia after LASIK that was first published by Theo Seiler in 1998 in the first reports on ectasia after high myopic LASIK, in which the impact from surgery caused ectasia. But a few months later, still in 1998, he published the foam fruits keratoconus defined as foam fruits based on the inferior stiffening, the nice interesting pattern that Jan Rabinovitz taught us. And these 2 reports allude perfectly to the pathophysiology of ectasia as described by Charles McKee, the 2-hit hypothesis. And it goes to any disease in medicine. The biomechanical decompensation of the cornea that any cornea may undergo is related to the corneal resistance and the environment. In the environment, of course, laser vision correction procedures can weaken the cornea and cause ectasia, but eye rubbing is the most common cause. And understanding that eye rubbing is bad for you is very important for every patient. I would say to every human being on the planet, but every cornea surgeon should consider that eye rubbing, scratching the eyes, or sleeping, pressurizing against the eye aggravates keratoconus, but may even cause ectasia. This is not the same thing, and eventually it's hard to distinguish in the clinical settings, but the distinguishing of those 2 situations, aggravating keratoconus and causing ectasia, is a very important prognostic factor for the patient. So the quest for enhanced diagnostics of corneal ectasia goes beyond, not over. And this is related to the subclinical cases. In this very nice report, bilateral ectasia after SMILE, which has a biomechanical advantage, El Nagar published that this patient has a mild abnormality on tomography. He said no to the patient, but the patient went to another colleague that didn't consider the tomographic data and did SMILE, and the patient developed ectasia. The pre-op data, however, would look at the front surface topography, right eye and left eye. Here you can see that the topometric data, even though the cornea is not steep, it's steepened. So this is a low K keratoconus. The K max 44.6 and 43.9 doesn't preclude the cornea for being steepened. And this irregularity is seen in the topometric indices. This is a front surface topography. And if you see in this letter to the editorial on the JCRS, we have the cutoff and sensitivity and specificity of topometric indices and also some tomographic data, including the BAD-D V2 and V3. And we are soon going to release the V4, which is more accurate, even more accurate than the third version of the Bell-Ambrosio display. In this case presentation, I come with the patient that has subbulbar keratomelosis, a thin flap LASIK with reasonable residual stromal bed, low PTA, and a little yellow here. And this little yellow here is still the mode of 0 on the classifications by experts using 2 different scales. The only change in the half diopter scale was that the vary was from 0 to 4, not 0 to 3. And the subjectivity goes into the domain of tomography. That's why we developed the Bell-Ambrosio display, which looks at front and back surface elevation with an enhanced approach that Michael Bellin was very wise to develop, excluding an area so that you calculate and you see, and this is a borderline difference, but when you see the BAD-D and Artmax are on the domain of ectasia susceptibility. If you want to remember those numbers, about lower than 400 Artmax and higher than 1.5 BAD-D are the numbers that I would suggest. But you have to understand that those numbers don't have a very, very high sensitivity for detecting subclinical or form-fruits or susceptible corneas. But you can go to the pentacam random forest using artificial intelligence and it gets better. It's very important to acknowledge that those cases here, if you see the fellow eye, you can develop the ability to see some abnormality, but if you see only topography, front surface topography, you would detect less than 25% of the cases. On the 105 series of cases that had LASIK, that developed ectasia, and then we had a pentacam pre-op data to analyze. In a very nice work collaborative with colleagues from Egypt, we published this series of 24 cases. And interestingly, the impact from surgery was not very high. Patients were not so young. BAD-D was abnormal in about half of the cases, but the pentacam forest would be able to detect the majority of cases. Interestingly, the need to go beyond is fundamental, and we go from the square to the cubic AA2I because we have applied intuition and going beyond. And going beyond with artificial intelligence is also understanding that we want to go beyond the human capability. Is not to do what humans can do, is to do things that humans cannot do, but not to replace human work, but to empower and to make humans more efficient to help patients in the best way as possible. This is very important. And we can go beyond tomography with high velocity shine flow camera for biomechanical analysis so that we can characterize the cornea. We have the CBI developed by Paulo and Ricardo Vinciguerra that you can see if the cornea is soft or stiff. And this is going to be very important on the integration with shine flow tomography. We have the TBI on the ARV display. The Ambrosio, Roberts, and Vinciguerra was honored to collaborate with Cynthia Roberts and Vinciguerra, Paolo and Ricardo for this nice work. And we have these 2 papers on JRS as the most cited papers in the among the most cited papers in the journal. So it's very important that we continuous improvement. This is the TBI V1 and TBI V2, which is an optimized function that was my AOS thesis. And this enhances the sensitivity for the very asymmetric normal topography eyes. And these patients here, some of them may be true unilateral ectasia, not unilateral keratoconus. Keratoconus is a bilateral disease, and some of these cases with fellow eye has abnormality on ectasia, but you were able to see no abnormality on tomography and biomechanics. So it makes the point that we should keep evolving, but eventually some of these patients are true unilateral disease. Interestingly, you don't lose sensitivity and specificity for the clinical keratoconus, and even you can see some better separation. And you can see some cases up here, which are the normal tomographic eyes that have some biomechanical susceptibility as we can consider. This is a very nice example of unilateral ectasia. The patient had a great result with a corneal ring. This patient was followed by Dan Reinstein. I did his surgery and in 2014, and he was followed by Dan Reinstein, who saw everything normal, including epithelial thickness, including the score with the Orbiscan data, and this was also normal on the TBI. This was not developed at that time, but we had the data. So in a retrospective calculation, we were able to analyze and see a normal TBI. And this patient even came back a few years later. He came back in 2018, and he was still very stable. Going beyond tomography and biomechanics, we go to the domain of segmental or micro-layer tomography. And this was first done by high-frequency ultrasound, this pioneer work by Dan Reinstein, and then popularized with the OCT. But Dan Reinstein taught us that the thinning of the epithelium is a very early sign of keratoconus because the epithelium thins to mask the irregularity of the bulging of the cornea. And this is something that was now popularized by spectral domain OCT, special work by David Huang and his team, especially Yan Li in his lab, in the Cool Lab, that was able to do the segmentation on the OCT. And now we have many OCTs that can do that. So the role of epithelial thickness that we started evaluating in 2013 is related to the pre and post-op of ectasia cases. This is a fellow eye of ectasia. You have a little thinning on the epithelium, and these are the three cases, three of mild, moderate, and advanced keratoconus. You see the thinning of the epithelium. Interesting, you have to be careful on the scale because blue means thin, and you see this red here that may be confusing if you just look at the red, but this thinning of the epithelium makes the point of a very advanced keratoconus case. We know that keratoconus can be distinguished by warpage from warpage because the inferior stiffening in the warpage, you have a thickening, and classically in mild keratoconus, you have this thinning pattern. So thickening here in this scale is red, and thinning here is in blue. And this case came as a very interesting example. This patient, 19 years old, 2050 uncorrected, 2015 distance corrected with a whole eye wavefront optimized manifest refraction. The cornea is a little thin in this young patient, and you see the scale is very symmetrical. The interesting thing is that the topometric data from Pentacam with the same scale makes it very similar, and even the indices are very similar. So this patient has a thin cornea, but has an abnormal D. The quad map makes normal elevation, but the thin cornea and the bad D with 19 years old makes it, I would say, susceptible. And if you look at the epithelium, this patient has a thick epithelium. This is the left eye, however. So this thicker area is nasal, and the thinner temporal area, agreeing that also the same would occur in the this is another scale. So you have, it's a very similar numbers. The difference is about 3 to 4 microns, but this is a patient that you see the tomographic and biomechanics, the TBI is very high. So it's confusing, but let's consider the fellow eye of this patient. The fellow eye of this patient has advanced keratoconus. So what about the epithelial thickening? The epithelial thickening in this case does not go against the hypothesis of Dan Reinstein, but the thickening is nasal. There is thinning. So the cornea is with a thick epithelium, but this is a thinned epithelium in the temporal area. And of course, the fellow eye has abnormalities. So looking at those two eyes, you can see the importance of going beyond, not over. And there's a true revolution in the OCT capabilities with different machines, excellent machines like the Cassia 2, the Revo, and the Imperium that are truly multimodal. The second hit is also very important. the RTA, the relational tissue altered, is going to include age, the thinnest point, flap, and ablation. I don't know, was very clever to be able to look at the difference between the number of patients who are much more stable than ectatic corneas, and the RTA is much better than the residual stromal band in PTA, so that we have a statistically significant way. And this is a welcome to the brain. Brain is going to integrate tomography, biomechanics, and relational tissue alter. If you are interested, take a picture on the braincornea.com, and welcome to see this new iteration of the software that's been available for about 10 years. So the enhanced susceptibility is to understand if you can do surface ablation, LASIK, SMILE, or the patient is a phakic IOL. But it goes also related to cataract surgery. This patient has mild keratoconus. You see, TBI is one in both eyes, and he had a multifocal toric IOL that was suggested to be replaced by a monofocal aspheric IOL, and the patient was much happier. And interestingly, the subclinical bilateral foam through keratoconus was what this patient had preoperatively. So if you want to understand why to do refractive cataract surgery, why you need to screen for keratoconus, it has an impact on accuracy of IOL power, it would impact quality of vision, and of course, if you want to do surgery, a secondary laser vision correction, you have to be keen to identify foam through keratoconus. And this is based on Shizuka Ko's data, a very common situation to have subclinical, mild, or susceptible ectatic corneas prior to cataract surgery. So in conclusion, this paradigm shift, we have to understand the whys, we have to understand the hows, multimodal diagnostics, beyond imaging, beyond refractive imaging to advanced molecular biology and individualized medicine, understanding the ability to understand the relational tissue alter with the brain software, for example, and of course, integrate artificial intelligence. All these are keen on the benefits of refractive surgery, which today is a true specialty in medicine. And we have to be fortunate to train and to do refractive surgery in this era of huge scientific knowledge so that we can help our patients in the best way as possible. Thank you very much for the honor to participate in the RIO, and I'm looking forward to seeing all of you soon. Thank you.